Hello, and welcome to the Center for Optimizing Rural Health's November webinar, Lessons from the Field in Addressing Burnout. I am Cassidy Avila, your moderator for the webinar today. Thank you for joining us. At this time, all participants are set to mute, but should you have a question during the presentation, we encourage you to go ahead and send it through the chat box just to ensure that we do get to your question during the Q&A portion of the webinar. If you do prefer to submit anonymously, you can choose my name, Cassidy Avila, from the drop-down box in chat, and I would be happy to ask your question when it comes time. It is now my privilege to introduce our speaker, Elisa Ares-Pagochaga. Elisa is Vice President of the American Hospital Association's Physician Alliance, a strategic initiative launched as part of the AHA's ongoing mission to improve the health of patients and communities. Framed around three fundamental beliefs that foster shared decision-making and create a path for common language among healthcare leadership, the Alliance advocates physician leadership through the educational offerings, professional development opportunities, and greater inclusion within hospital and health systems administration and policy activities. She received her master's degree in business administration with a concentration in healthcare policy from Keller Graduate School of Management and a bachelor's degree in biology and Spanish literature from Amherst College. So Elisa, I will now hand it over to you. Thank you for being here with us today.
Thanks so much, Cassidy, and hopefully you can both hear me and see my slides.
Yeah, you sound great.
All right, thanks. Always like to check in our Zoom environment. Thank you for having me, and I'm excited to talk to you a little bit about some of the lessons we've learned from the field in both addressing burnout and, as I have started to say it more often, is really around building resilience. So what I'm going to talk about today is really these three areas. So understanding where work-life balance comes from, and what the role is both at leadership levels and at the personal level for addressing burnout in our healthcare systems. Understanding some of the steps for organizational well-being, and I'll walk through our toolkit that we have available, and I'll share where that is as we go through. And then share some of the case examples from organizations around the country who have been doing this work for a while. I'll also talk a little bit as we get into this about the some of the differences and nuances and approaches relating to specifically to the impact that COVID has had on our healthcare teams, which has been quite significant. So I imagine many of the leaders on the phone, even before COVID started, often started their days like this, with that feeling of, oh gosh, I've got another day to get through or another week to get through, and there's just too much to do. And one of the reasons I always put this up, I want to be clear, burnout is not just about physicians. This may be where we first noticed it and first started talking about it. But the most important part of this slide is the fact that this was an article in the New York Times in 2012. This is not new. It's not, and it's not personal. It's something about our healthcare delivery system that is driving, in this case, at this point, almost 1 in 2 physicians to be burned out, and is continuing to impact the rest of our healthcare system. So we really need to understand, where is this coming from? We almost don't understand what we've built and how we've built it between regulation and all of the needs of the system. We have a large group of people who really want to help other people. That's why I've never met anyone in healthcare who didn't want to be there, who didn't do it because they want to help other people. And yet we've built a system where we're slowly harming ourselves. Now add to that the fact that we are in the middle of a pandemic. We've gotten some really good news in the last couple of days in terms of the announcement from Pfizer about the significant efficacy from their trials, the emergency use authorization that has just been put out for the therapeutic, the monoclonal antibody therapeutic. I'm hopeful that we will understand and solve for COVID soon, I guess, is how I'd say it. But before COVID, many hospitals, 1/3 in fact of the hospitals in the country, operated largely in the red. And that's due to historical payment trends. But you'll notice in the graph that Q1 of this year, it was up to 50%. And those purple bars on the slide are projections that were done in July. And the full report for this is available at aha.org if you'd like to read into it. But I expect that by now we are close to 50% of hospitals operating the red, which means there is no room, no margin for error, and no margin for doing any of the things that we could be doing to support and help and really engage with our teams where we're really at that red line. And COVID really has been the largest financial threat for US hospitals. Our estimates are that hospitals have lost or will have lost by the end of this year over $323 billion. So it's just a significant challenge on top of a system that was already challenged. What caused some of this? And you all know this as well as I do, being prepared for a surge, whether that surge hit you in March, April, May, whether it's hitting your organization now, means you may have paid quite a bit for the PPE you have in stock. You may have had to bring in staff from other areas or from agencies. You are doing amazing work, and I'll talk about some of the examples we're hearing from across the country to support your teams, to make sure that they have what they need in terms of everything from childcare to hotel accommodations, so they don't have to be going home every day fearful that they're spreading COVID to their families. All of the infrastructure needs and upgrades, whether it's tents in your parking lots for COVID testing, to taking over gymnasiums to create additional inpatient space. All of the shutdowns and slowdowns that have limited outpatient care, have limited routine care, have limited many of the non-emergent surgeries that support your bottom line. And then all of this economic impact has increased the number of uninsured who are needing support as well. And at the same time, what we're hearing from healthcare professionals, and this is from an article by Shanafeld just earlier this year, I believe it came out in early May, was a very real concern about how we can help protect our nurses and doctors and respiratory therapists and all of those who are doing their best to protect and serve those who are ill. Everything from really understanding what this disease is and listening to their expertise, protecting people, all the PPE needs, making sure that we understand what we need to be doing. I know a number of organizations have done everything from cross-training their teams to work across settings to greatly investing in telehealth capabilities and helping people get up to speed as quickly as possible there, to really supporting their team members, whether it's through safe spaces where they can decompress, whether it's additional access to chaplaincy services or EAP, employee assistance programs, or other supports for a team that has probably, if they're in a hotspot area, seen, more trauma and death than they may have seen in their careers. And then really making sure that we're providing that support for our teams. All of this relates very closely to many of the personal resilience influences to burnout. Now, I point this out because there are really three areas of influence on what we have traditionally talked about as workplace burnout. One is the personal resilience that you bring to your job. And in fact, among physicians, medical students are actually more resilient than their peers when they start medical school. Unfortunately, by the time they finish residency, they are less resilient. So there's a clear problem in some of the ways we do things. And I know there's work being done there. But the other two pieces are very much a factor in how burnout manifests. One is the environment and the immediate environment, the health system factors, the places you go and interact every day, and what are those processes and programs that are in place that are controlling how you interact with the world. And then there are the bigger regulatory and cultural factors, things that are related to how we must do things for payment reasons, how we as Americans choose to want our care delivered, and all of those factors that are broader than your immediate care environment. And all three of those interact and really address and cause some of the impact. So thinking back to that environment, if you think about what's happened over the last decade, there has been a significant shift from in our focus, in how we care, in looking at what our goals are, how our rewards are driven. And unfortunately, the shift has not, been a light switch of a shift. I say unfortunately because I feel at some point we might have been able to just accommodate that switch with maybe a lot of pain and challenge, but we've continued to build towards this future state, this ideal state, and it's been very disrupting, which can drive additional burnout. Now, we know burnout is a problem. We understand that, whether it's an impact on patient safety, on patient satisfaction, higher costs, increased turnover. And last year, I know the Annals of Internal Medicine put out an estimate that physician turnover, and this is specifically just physician turnover as opposed to the data that's on the slide related to nurses, could be as high as $6 billion a year, just covering that turnover. And one of my, the studies that most spoke to me is one that was done out of Stanford, where they identified their scores on their burnout survey with patient recovery times for elective surgeries, and actually found that those patients, controlling for other factors, those patients whose physicians, whose surgeons were burned out or scored higher on the burnout scales, actually took about 10 days longer to recover from those elective procedures. So it's definitely a problem we need to address. It affects so many factors. And I think most importantly, it hurts the people who most have spent all of this time and effort and energy to get to a place where they can help others. So how can we support them? And as I said, there are a lot of those factors that come to us from the environment, the regulation, the way that we work. And it's not that much of a surprise, and I don't think anyone who's dealt with an electronic medical record would be surprised by any of these numbers on the screen. But we're seeing our clinicians spend nearly half of their workday in the EHR, and about half of that time being spent on inbox management, order entry, billing, or my most favorite, the re-entering your password because it's timed out because you stopped to do something else. So there's a lot of challenge. I think there's a sense that this is the best potential description of an electronic health record. And I don't know that the promise has necessarily resulted in the reality we had hoped for. So I know it's a huge level of frustration certainly for most physicians and for many others. And this is one of the reasons why. this is a study that was done, I believe it's about a year ago now, where they looked at the hour of day that physicians were in the EHR. This was done by a team at the AMA. And so that's, that curve starts to climb around 7 in the morning. That's the hour of day at the bottom. Starts to climb at 7-ish, runs pretty high at the top there till about 6 p.m. and then drops off really quickly. That's the dark line is the weekday, and then the weekend is the dotted line. I'll draw your attention to this particular circle. That means that basically between about 8 p.m. and 11 p.m. on a Saturday or Sunday night is a prime time for most clinicians to be in their EHR. Not exactly date night, but that's disturbing that this is what clinicians are doing after hours. So we need to take a look a little further upstream to understand why all of these challenges seem to be manifesting together. So starting with the woman who coined the term burnout, Christina Maslach, in a paper in 1980, these are the domains that she really correlated to burnout, really understanding the workload and not necessarily the amount of work, but also, is it the right kind of work? Is it work that brings you purpose and meaning? Is it emotionally draining? The second, which I'll point out, there are two of these I really consider really essential, and this one, control, is the next one, is the second one. The idea that you don't have control over what you need to pursue your work most effectively. I find this one, especially with physicians, not having the resources or the access or the authority to provide the care you think your patients need, is one that I've had cited to me so many times as a challenge. Not feeling like you can be effective in your job because you don't have that control or access or authority. Next one is rewards, the lack of appropriate rewards. These don't need to be financial. They can be social, intrinsic, the joy in doing what you feel you are built to do. It can be a lot of different things. Community is one that I feel is the second one I feel is so important. That lack of connection and commiseration, compatriotism, again, especially going back to the physicians, and I realize I keep referring to them. That's where I've done much of my work, but this applies, I think, broadly. But especially with physicians, they train as a team, they train as a cohort, and they go through medical school and residency together. And as they advance in their careers, they may separate more from each other, and not having that community to support you, that team that does what you do to support you, can be very challenging. Fairness, certainly very important, that lack of perceived fairness and mutual respect. And then values. I'll talk more about values, especially value alignment between leadership and the team is really a huge one. So I want to get back to this idea of workload. And a number of studies have been done to show that it's not entirely the number of hours. I know very few physicians who work a 9-to-5 day, or very few people in healthcare, let's even say, who work a 9-to-5 day and go home and are done. It's the ability to know that you can get done what you need to get done to feel like you've made a difference and been effective, that really is what drives people. And I think this is another one that, again, specific for a physician's study, but I think this would correlate out to everyone on the team in a clinic. The more that you feel you can support your patients and your community, the more you feel you are being effective and the more satisfaction you have. as I said, I don't know anyone in healthcare who got into it for really deep down a reason other than they wanted to help people. I'm going to switch gears a little bit to talk about another influencing factor that I don't know that existed in the same way back when Christina Maslach wrote her first paper, but I think is a key to what we're facing today. I want you to think back to this morning. It's around noon Central Time. How many times did you even this morning, in the last 24 hours, talk about how busy you are? It's become the badge of honor to some extent for not even our generation, for several generations now. This idea that we are very, very busy. And it's been an interesting switch in that 100 years ago, the badge of honor and sort of a sign of how well off you were was how you spent your leisure time. And now it's about how busy we are and how much we can get done. So I highly recommend the Harvard Business Review article that's linked here. But this idea of busyness, I think, impacts us in that we are often entering our days in this sort of sustained moment of hecticness, that we are moving from thing to thing to thing, moving at half hour or hour increments, and not ready to focus on the next thing until we are through the thing we're currently in. And what actually happens is our ability to focus gets smaller, and we can really only concentrate on the most immediate, low-value tasks. Check something off my list. Let me get something else done as fast as I possibly can. And it turns out, according to this study, that we actually lose about 13 IQ points when we do that. So we actually literally get dumber as we do that focusing, that tunneling, that only doing what immediately needs to be done. And I'll share from my own life an example of when I know I'm doing this is when I go through my inbox, which might be overflowing a little bit, and I go through and I accept the calendar invitations. If you have Outlook, you've seen this, because that clears out a few messages and I don't really have to interact with them. So if you find yourself getting late in the day and starting to do that, maybe think about whether there's something that can come off that to-do list. The other important point here is that when we do get into this tunneling phase of just moving so hectically, it actually narrows our ability to do the long-term strategic thinking work that allows us to move forward. So we're actually lessening the time that we have to do that. So it's certainly a way that we can continue to sort of perpetuate that burnout and not feeling like we have time to think. I'm going to switch gears again because I've talked a lot about the personal and the personal impact of some of these systems. But I think there's one really important issue that the rest of what I cover will talk about, which is we all know culture eats strategy for lunch. But as a good child of the Jaws era, there is definitely something lurking out there in the deep water, which is infrastructure. The idea that unless we make it easy for people to do the right thing, they will default to doing whatever is the easiest route, because we are all very busy and very dedicated, and we don't want to not do something for lack of an easy way to do it. So the infrastructure and ensuring we have the infrastructure to support this work is important. It's so important. So I'm now going to talk about some of the examples and some of the work that we've done to really enable some of that systemic change. So I'm going to walk through our well-being playbook, which we published last year. It's available on our website. It's available to download for anyone. It collects, you'll see a number of steps of how organizations can think about this work, but then a large number of case examples of work that's been done at different organizations of different sizes and shapes and formats, and different work that's been done for each organization. I want to emphasize that point, that while the steps are relatively the same for each organization, you'll hear through some of the examples I share, and then if you dig in on the website, this work needs to be adapted to what your organization needs and to what your organization will best thrive in. And you need to really think about what are the things that you can do in your organization and what can best support your own teams. So the first step in our list is really creating the infrastructure for well-being. It is, as I said, with the shark, without that infrastructure and that support and knowing that you can go back and lean into this work, it will be too easy for this to be a project that fades away. So knowing how to have that infrastructure, that accountability is really important. I'm going to tell you a little bit about some work that the University of Rochester did. This is a 6-hospital academic system, which has a large academic medical center and then a number of very small hospitals that are part of their network. And they're actually, I think, larger than 6 from this example is we wrote up last year. I think they have more hospitals than that now. But one of the things that Dr. Privatera, who leads their work, has done is really study the impact of stress and burnout on the brain. He's a psychiatrist and has done a lot of work in this area, and really looked at the impact of the human factors and ergonomics on what happens when we are under stress and repeated stress. And he's actually published several papers on the amount that it reduces our executive function, our ability to connect disparate ideas. But he also realized that functioning in an academic center and then with hospitals spread out across upstate New York, that he needed to tie this work to a well-established sort of business case, if you will. He realized he needed to talk about this with different audiences in different ways. He needed to talk about the amount of money they could save, whether it's through medical insurance claims or malpractice, but he also needed to talk about it through the quality lens. What were the quality improvements that they were going to see if they really supported their teams? And then he talked about it in terms of the patient satisfaction and where they could see greater connection between patient satisfaction and burnout measures. So again, he looked at it from all of these different angles and helped convince the whole team that they needed to create this infrastructure within the organization to really support well-being across the team. And again, all of these have much more detailed write-ups on our website, so you're welcome to take a look at those. The next piece I'm going to talk about is really engagement. I would venture that every single one of your teams knows how to fix things in your organization. They may be right, they may be wrong, but they have ideas on how to fix things. And that one of the best resources we have is to start with team engagement to understand that. So at the time, the CMO at Avera, they have nearly 300 facilities, including 33 hospitals across several states. They realized that as the CMO, Dr. Jacobs was realizing that there wasn't really a whole lot of use of the employee assistance program resources and some of the other resources relating to addressing burnout. Even though they had them available, they were there, but they weren't seeing a lot of uptake. And so he got together with the director of the employee assistance program to say, okay, well, what can we do that is going to make a difference and get people to use these resources if they need them? What's the point of having them? And if we're really going to build this program, we have to show that it has value. So what they did was create this program they called Light, where they really focused on 3 areas. 1 was around executive coaching. 2 was really promoting their online resources. And 3 was building some social events, which I realize we have a little more challenge to do now, to bring people together and build that community. But I think one of the things I really loved about this story was that one of the pieces that I'm not sure that they realized how valuable it would be is the spouse group that they created for their clinicians on Facebook, who actually took over organizing a good number of the in-person activities and have continued to support this team. Again, one of the things that they were able to do was look at ways to support this by saying, we've reduced our malpractice, we've reduced our recruitment needs, so let's continue to invest in this work. They made sure to do the next thing, which is to measure. So while I will advocate always to measure and understand where you are, the worst thing I think one could do is try to measure well-being and then not do anything with those results. So in the toolkit, we link to a number of validated tools that are available for measuring well-being. There are 7 or 8 good ones that all have different nuances about how they work. And I think there's a lot of value in understanding where the team is, but you need to do something with those results. So I'll tell you a little bit about what the Minnesota Hospital Association actually came together to do. Their chief medical officer, who's now actually their CEO, brought together almost every hospital in the state of Minnesota to say, okay, let's understand first, what are you doing around clinician burnout? And second, let's measure it as a state. And what they were able to do was track where the burnout was across their state, but also then tie it to interventions. So they could see where, because they've been doing this now for, I think, 4 years, every time they have an intervention that's been deployed, they can see how they're performing, both compared to their own numbers, but then across the state, which has been really helpful for the organizations in Minnesota. So now, once you've got the data, you've asked your team, you've got the infrastructure, you've got the leadership, you know where you want to go and what you want to do, this is where your team can really help design the right intervention. I think probably some of the key lessons we've heard here, and especially now in the time of COVID, is flexibility in allowing teams, units, pieces of the organization to help design the solutions that are going to most support them. For some, units, it may be just, as I mentioned, having that safe space with, some comfortable chairs where the folks can go and just decompress for a few minutes between patients, between shifts, just to clear their minds and really create space. It could be as simple as one floor where one of my colleagues at Hopkins mentioned, where they had a number of new mothers on their service, and by sort of taking over a supply closet and putting a lock on the door, they created a room for those new mothers to be able to pump and, still be at work and function with their jobs and not have to go halfway across the campus to do that. And, you know, as Eric describes it, it was basically the cost of a $3 lock to put on the door that made all the difference in the world to those moms. So it can be simple, it can be complex, but it needs to be about fixing what needs fixing, and not fixing what I think needs fixing, and not what doesn't need fixing. So this is an example from the Atlantic Medical Group in New Jersey. Again, a large medical practice, and their challenge was that they were rolling out EHR, their Epic EHR, folks had different challenges with it. And so they created basically this takeout menu of training so that they could go to busy physicians and say, what do you specifically need help with? Let us tailor our training to you. Let us follow, you for a day. Let's understand what it is that you need versus offer you a 4-hour training of which you needed 20 minutes. So they really asked people to help them design the solution that they would find effective. Now, this is, as I mentioned, a really large medical group, but the same lesson could apply to any organization. They really asked them to help design the solution. Obviously, the next step is really implement these programs and really spend time studying them, evaluate what they can do. This is going to sound real familiar to anyone who's done quality improvement. It sounds remarkably like a PDSA cycle, but really take the time to both implement and then evaluate what kind of impact they've had. And don't be afraid to step back and say, this didn't really do what we thought it would do. Let's try something else. And I think the most important piece is to create this sustainable culture. Now, this is the hardest step. Maybe it's why we put it last. But it can take as much as 3 to 5 years to shift a culture in an organization. But it is essential that there be a mindset shift to really support this type of work. I think there is more acceptance for this now. In particular, we're seeing many of our caregivers really needing the support from their colleagues and their colleagues needing it. I think we've all adjusted and turned our own lives upside down enough that we all want a culture of well-being in our organizations. Now, while I will tell you this cannot just be done from the top down, it really needs to be bottom up and top down. There is one thing that's real important: leadership matters. Whether it's a study that was done at Mayo a few years ago, about 4,000 physicians were interviewed about what they think about their leadership. And for every 1 point increase in the answer to "my leaders treat me with respect and are interested in my opinion," there was over a 3% drop in burnout and almost 10% increase in satisfaction. So if you're interested, whether you're interested in your team's opinions, whether you're treating them with respect, that's making a huge difference in how they're reacting. So I'm going to share one final example here, and this is from Novant Health in North Carolina and South Carolina and Virginia. And they realized several years ago, and in particular, a lot of this work has been led by a physician, family practice doc, who realized that he didn't really like who he was becoming in service of doing everything he could to serve his patients. Not that he didn't, his patients loved him. They thought that he was amazing, but he was getting to the beginning of, every morning and he was looking like that cell phone battery I showed in the first slide. he wasn't feeling fulfilled by his work. So they have been doing over the last 4 years now, because they've done have been doing it since 2016. They created this leadership development program, which includes a lot of work on a lot of different topics, but really is about the self-leadership and addressing the burnout that comes when folks are challenged in that way. So I quote a number there on the slide about their rise in overall employee engagement, which is amazing. And that's just over 2 years, from 62% to 89%. What I actually find more interesting, which is in the longer case example, is that their physicians specifically moved those who went through the program, their engagement was at 97%. Amazing. But what happened was that the teams that didn't go through the program, but reported to those physicians or worked with those physicians who did go through the program, over those same 2 years, their engagement went from 54% to 82%. So they didn't even need to go to the program and really, participate in it for the impact of their leaders really looking at their own leadership and how they support their team's well-being. So this is one of my favorite things we get to do. We actually have partnered with Novant to offer this program. Obviously, it's been on hold in 2020 given the pandemic, but we hope to continue doing them in 21, where we really dive into how leadership and self-leadership ties to well-being. So I've been talking for a long time. Gonna just wrap this up with a couple more slides. These again are the 7 steps. Importance of infrastructure, ask your team, measure what you're doing, try something, and then try the next thing, and then try the next thing, but make sure you're evaluating it and improving them as you go. Just want to make sure you're all aware, the AHA Physician Alliance, which I lead, has a number of resources related to burnout and well-being. We also have resources related to leadership and leadership development, particularly in the physician space, and then related to how physicians can engage on addressing the care of our communities and healthcare system redesign. All of our resources are available at aha.org/physicians. So to sum up, 3 key takeaways I would share with you from what I just said. So if you remember nothing else of what I said today, these are probably the most important. This is a cultural shift and change will take time. So keep at it, keep supporting each other, keep understanding that your support and love and caring for your fellow teammates and your fellow man are what drive a lot of this work. A strong infrastructure is there to support a good culture and is essential to supporting it, and that you need everybody on the team. Top down, bottom up, everybody in the middle. You need the whole team to be involved in this work if you really want to be effective. So I'm going to wrap up with one piece. I ask this a lot at presentations that I give, if anyone knows what this number is, and I've gotten all sorts of different answers. If you have a thought, type it into the chat. I'll give you a second to do that. No guesses?
I don't see anything, Elisa.
All right.
Well, I did have something come to me. It says % that one person needs to be happy to prevent burnout.
I like it. 168 is actually the number of hours in a week. So I challenge you all on this call. You've spent about 45 minutes listening to me. So this might count as your hour, but what might you do for an hour next week to address either your own level of burnout, because as leaders, you're statistically less likely to take care of your own well-being, or to help the well-being of your team. I'd love to see some examples in the chat. I always learn so much when I ask people what they are going to do. I've seen everything from, bringing baked goods in one morning to, really just reaching out and connecting with team members. So I'd love to see some ideas, and then I'm happy to pause and ask if there are any questions, Cassidy, or anything I can expand on.
Sure, thank you. I did have a question come to me privately in the chat that I will ask on their behalf. The question is, do you take into account the difference in burnout triggers for women versus men? For example, if women report lack of work control as a cause for burnout, but men do not, should we be addressing burnout differently for male versus female employees?
So there are studies that have looked at the difference in burnout, and I will tell you in particular, for women, there is more challenge. Part of that also relates to, in general, they often lead when it comes to the childcare and house operations, if you will. So I think part of the nuance needs to be, you need to think about what are those things that are going to assist different groups in your organization. So it might be worth bringing together a group of women in particular, if there's interest, to say, hey, what are the challenges you're facing? As I mentioned in the example at Hopkins, they, it happened to be a team that had several new mothers on the team for whom this was a challenge. They, and as they talked about what their team needed, that was one that they identified. So I think the solutions do need some nuance. So encourage you to, as much as you can, bring teams together to talk about where they find the most challenge.
Thank you. And then there are a couple of things coming through in the chat. So someone mentioned that they have a morale building meeting scheduled for next week. Let's see. Start meetings 5 minutes after and end 5 minutes before the hour or half hour to give time back to get a drink or use the restroom or prepare for the next meeting when they have back-to-back meetings scheduled.
Kelly, I am nodding vigorously as someone who often is scheduled from morning till night. That is one that we've implemented here wherever we can to make meetings run around 45 to 50 minutes. Yeah, I will share one more example of something we do here just to highlight that it doesn't need to be big. Our team meeting on Thursday mornings, we always start with what we refer to as Small Accomplishment Thursday. So everyone gets to share, or whoever has something to share, shares just a small thing they did that, either they had been putting off or was a little more of a challenge, or personal, professional, but just something that somebody did that they felt good about having finally gotten done. And just taking a moment to celebrate that little win can really make a huge difference and start to move that culture.
Excellent. And then Bree had said, I see now that you can see the comments, Elisa, but Bree says, thank you. She appreciates the emphasis on and the data that you presented on culture and infrastructure. It's good to see this change from when the perspective was on individual characteristics.
Absolutely. This has to be a marriage between individual and personal resilience and making sure that you're taking the time to do that. but then you have to ensure that the structure and the organization supports that. Because if it doesn't support it, it's going to win every time. The infrastructure is always going to win. All right, well, Cassidy, to support our ending with enough time for folks to get another drink of water and go to the bathroom if they need to. If there aren't further questions now, we can wrap up, but I also put up on the screen my contact information. If you'd like links, any of the links I mentioned, any of the details, I am happy to share those. And feel free to reach out to me. This is one of my personal passions and one I love to talk about, obviously.
Thank you, Elisa. It was a very excellent presentation. And we thank you all for your time today, and we welcome any follow-up questions that you may think of. I did share the link to the AHA's Physician Wellbeing Playbook. And as Elisa mentioned, we always send out a follow-up email, and we will also include any links that she had in the presentation as well today. And I also shared a very quick 1-minute survey link. So if you, let me get some, 1 second.
It's crazy.
There, I think I took care of that. Sorry about that. I shared a 1-minute survey link. It's truly just a 60-second survey. So if you have a second, that just tells us what you thought of the webinar and then what you might like to see in an upcoming webinar, because we do determine the content of these webinars based on your needs. So again, we thank you. Have a wonderful day, everyone.
Thank you.
Thank you so much, Elisa.